Hello everyone, my name is Brooke Regier, you all knew that. I am a second year CRNA student at Samuel Merritt University. This presentation is called RSI Survival Guide, Things I Wish I Had Known as a CVICU Resident. And this is for my class, Nursing 701, Improving Health Outcomes. This video provides a brief overview of the RSI technique frequently used both in anesthesia and critical care, and describes the small differences in technique based on where in the hospital the RSI is being performed. In addition, this video goes over 5 medications included in the standard RSI kit found on the unit and discusses their mechanisms of action, indications, proper dosing, onset and duration, and any associated adverse events that we need to be aware of. The goal of this video is to give CVICU RN preceptors in-depth teaching points to pass along to their new CVICU residents and fellows that may be new to the CVICU, the ICU, or even nursing as a whole. Knowledge is power, and my goal is to empower all of you for the safety of our patients and for the incoming generation of nurses who rely on us to educate and prepare them. And at the end, I'm going to open it up for questions and discussion. RSI. Okay, so we all know that the RSI stands for rapid sequence induction. This technique is typically used as an emergency protocol on the ICU when a patient is decompensating and we need to secure their airway. I think we all understand that typically the nurse's role in an RSI is to prepare and administer medications. So what I want to do is go over those medications with all of you and share with you some of the things I've learned in school about those meds and how I wish I had known them as a nurse, both as a new nurse and as a nurse teaching others. A little fun fact, we do use RSIs in the OR all the time. They're not necessarily for a patient that's decompensating, but more so it's used for someone who maybe has a full stomach or has really uncontrolled acid reflux and we want to prevent aspiration. So what that means for us is we are giving higher doses of paralytic. We're not giving the medications time to circulate, but we're rather just pushing those medications really quickly and then going ahead and instrumenting the airway. In addition to just this really sped up version of a standard induction, we're typically applying a little bit of pressure to the cricoid membrane, and that is just to help occlude the esophagus and bring those cords into view. These are all probably things that your physician is thinking about and not verbalizing, but just a good thing for you to know in the back of your head that the physician is maneuvering the airway in such a way to prevent aspiration and to protect that patient's airway. Propofol, everyone's favorite drug. Okay, so we all are familiar with how to use propofol on the unit as a drip. It's included in that RSI kit. However, I feel like it's rarely used because our patients are already typically disinhibited, losing consciousness, unstable hemodynamically, and not appropriate candidates for propofol. However, it's still in your kit. You should still be educated on it. And our new nurses should definitely be educated on it. So the mechanism of action of propofol is it's a GABA receptor agonist. GABA is our primary inhibitory neurotransmitter in the brain, so it induces that sense of sedation, sleepiness, hypnosis. The proper dose for a IV push of propofol is 1 to 2 milligrams per kilogram. 1 to 2.5. A great way to split the difference here is to take your patient's weight, 70 kilograms, and just double it. 70 kilogram patient, an appropriate propofol dose for this patient is going to be 140 milligrams or 14 milliliters. The onset is less than a minute and the duration of action is 7 to 10 minutes. So your physician knows that once they see you push that propofol, they have about 45 seconds until they can start instrumenting the airway, and they have about 7 to 10 minutes to have that tube in. Typically, our physicians are pretty good and they get those tubes in really quickly. But if you are using propofol for whatever reason and running up against that 7 to 10 minute mark, you may need to redose. Actually, anecdotally, you're probably going to even need to redose sooner. Adverse effects, it decreases all protective airway reflexes. So this makes the patient much more susceptible to aspiration. Something that we don't see on the unit because our patients are already very disinhibited is propofol can definitely cause pain on injection. It can cause a burning or a tingling in the arm at the IV site, and this is just due to the preservative that's in propofol. Additionally, we all see this, it causes myocardial depression, especially in these very potent IV pushes. You're going to see a very substantial drop in blood pressure and sometimes heart rate. And of note, there's no analgesic effect in propofol, so just be mindful of your patients and their analgesia. Consider some sort of adjunct or drip for your patients who are receiving propofol. Something really cool I've learned about propofol that I love is it's a potent antiemetic. So even just a small little bit can help decrease nausea and vomiting significantly. Etominate. Etominate is a drug I didn't know much about as an ICU nurse, and I'm going to be honest, I still don't know much about it as a CRNA student. Maybe I'll see it in cardiac anesthesia, but it's a drug that's fallen out of favor with most of the general population. So the mechanism of action is similar to propofol. It's also a GABA receptor agonist. The dosing, while this may not be super relevant now, is just a good thing to file away, 0.2 to 0.4 mg per kg. The onset is greater than a minute and the duration is 3 to 5 minutes. So it's going to take longer for that drug to set up, and the duration of action is going to be shorter than with propofol. Adverse effects of etominate are really cool, really good to know in regards to your long-term patient outcomes on the ICU. So to start, there's no analgesic effect, which shouldn't matter much during an RSI, but what does matter in the long term is that etominate can induce adrenal suppression. So research shows that critical care patients experience adrenal suppression typically around day 4 of hospitalization. This is because their bodies are working endlessly, tirelessly to maintain homeostasis, to maintain hemodynamics, and the body depletes all of its endogenous catecholamines around day 4. If you're like me, you're not going to think much of those stress dose steroids showing up on your MAR, but if you think about it, it's typically around day 4. So it's actually a very intuitive decision that they've made to help support the patient's endogenous catecholamine production. All that to say, etominate does induce adrenal suppression. So if your patient is new to the ICU, you could put them into that adrenal fatigue early on in their stay. And stress dose steroids may be a good suggestion to make to the interprofessional team to prevent any more adrenal fatigue. Of note, as I said on the bottom, etominate is great for cardiac patients. It's got a stable hemodynamic profile despite causing that adrenal fatigue, and it's good for patients with a decreased EF. So you're not going to see these huge immediate drops in blood pressure, these big swings in hemodynamics. So typically that's why it's included in the cardiac RSI. Okay, now we're going to talk about rocuronium versus succinylcholine, and I feel like this is kind of the heart of the presentation and what I wanted to get at, because this is something that I didn't understand as a new CVICU nurse, and it's something that I wish I would have, just because I think it would have made me more informed in those emergent situations. Okay, so when it comes to paralytics, they are all acting on the neuromuscular acetylcholine receptor that's in the muscle tissue. Rocuronium is considered a non-depolarizing antagonist. So the neuromuscular acetylcholine receptor has a bunch of little subunits on it, and among those it has 2 alpha subunits. And rocuronium is binding to one of those subunits, which is then not letting acetylcholine bind to both, so that receptor can never activate, leading to paralysis. In comparison, succinylcholine is considered a depolarizing agonist. Instead of binding to one little alpha subunit, it binds to both alpha subunits. So succinylcholine actually mimics acetylcholine, and so it causes the receptor to be perpetually turned on, essentially. And that's evidenced by the fasciculations that are seen in the patient when you push this medication. So the dosing for rocuronium is 0.6 to 1.2 mg per kg. A really quick way that I do this in my head in the OR is I multiply 6 by, if our patient is, say, 70 kilograms, I'm going to multiply 6 by 7, and that's 42. So I'm going to use 40 milligrams of rocuronium, which is going to be 4 mils. Typically, a physician would ask me to drop 5 mils or 10 mils, and so I would do it, and I didn't really know why. Now I kind of have pieced together all of those experiences in my head. 50 milligrams is typically going to be enough for anybody. However, when we're doing an RSI, we want that medication to be onset as quickly as possible. Using the lower end of the dosing scale is going to mean a longer onset. So you're going to be closer to that 3-minute mark. If you use the higher end of your dosing scale, closer to 1.2, so 70 kilo patient, you're going to be using roughly 70 milligrams, 7 milliliters. Your onset's going to be much quicker. It's going to be closer to 45 seconds, which is going to be much more suitable for an emergency situation. So typically just draw up that full 10 vial and take a glance at your patient's weight, keep their kilos in the back of your mind, and just make sure to check that physician. Make sure that you're giving this patient an appropriate dose for the situation. Duration of action of rocuronium is going to be 30 minutes. So it's going to take 30 minutes for that drug to circulate through the body, bind to those receptors, and then come off, allowing those muscles to work again. So just ensure you have an appropriate vent mode that's going to allow this patient to be fully supported for at least 30 minutes until their twitches come back. Okay, back to succinylcholine. We have receptors that are going to be activated and on for about 7 minutes. We see this almost, if you look really closely, the next time you're in an RSI and you're pushing succinylcholine, they're almost going to be like twitching all over the place. And this is because those receptors are all kind of firing. It's really cool. The dosing is going to be 1 to 1.5 milligrams per kilogram. So it's actually going to be a very similar dose to rocuronium, in the sense that it might just be 1 mg per. This drug is super potent. It's very effective. It works really quickly. Usually the onset is less than a minute. So a physician might choose succinylcholine versus rocuronium because it onsets much quicker and oftentimes gives the physician much better intubating conditions. And it wears off in 7 minutes. So if you're trying to be really aggressive in weaning this patient off the vent and you want them maintaining a spontaneous respiratory rate as quickly as possible, succinylcholine is a much more appropriate drug. Succinylcholine does come with more adverse effects to be aware of. It releases histamines, which means that you may see a subsequent drop in blood pressure. It also can cause a potassium efflux, so any of your renal patients that you're doing an RSI on are not appropriate candidates to receive succinylcholine. Additionally, it can cause bradycardia and asystole in pediatrics for anyone that may pursue pediatrics in the future. It can also cause malignant hyperthermia, In that instance, if it were to happen in the ICU, your patient would have lockjaw, your provider would not be able to get an ET tube in, and you would be in the midst of a serious airway emergency. Additionally, it can increase intraocular pressure and intracranial pressure. So if you do have a patient that you're concerned about their neurostatus, succinylcholine may not be the best choice, and you would probably opt for rocuronium. Phenylephrine. We've all used this medication. It's a highly versatile med. It can be used as a drip or a push medication. And it's included in that RSI kit, so don't forget that it's available for you to use. I think it's highly underutilized in the RSI on the unit. The mechanism of action, it's an alpha agonist. There's no inotrope effects with phenylephrine. It's used for vasoconstriction only. The reason it's a valuable drug for the RSI is our meds typically vasodilate our patients, and this is a great way to counteract that really quickly if you're not going to use something like fluids or any other vasopressors that you maybe don't have in line. Proper dosing is going to be 50 to 100 mics PRN, titrate to effect. Onset is less than a minute, duration is 10 to 20. You can redose as needed. Adverse effects, this can cause a reflex bradycardia because you're all of a sudden causing a vasoconstriction, and the body is going to counteract by altering your cardiac output by dropping your heart rate just to keep everything within normal. It's an easy medication to use. 1 ml is going to be 100 mics. I once had someone in the OR tell me that it's really hard to kill anybody with 1 ml of anything. So if you aren't sure or can't remember in the moment or are advising new nurses, 1 ml is always going to be a great dose to start with. And this is just a little summary slide of everything we talked about. It's got a nice comparison side by side of all of the major factors: mechanism of action, dosing, onset duration, and adverse events. Hopefully this is helpful to nurses we're teaching, educating, for you guys in the future. I'd like to thank everyone for their time, and now I would like to open it up to questions and comments.